Hello, everyone, and welcome to this episode of Stewarts Soundbites. This time it's a recorded session. I'm Nichola Fosler, and I'm a partner in the personal injury team in our London office at Stewarts. And today I have great pleasure in being joined by Dominic Atta. Dominic is principal orthotist at Blatchford in the south. He has a Bachelor of Applied Science and Masters of Clinical Prosthetics and Orthotics from back to 2018. He started his training in Leeds and then moved to London. But he has worked across a whole range of NHS clinics, including acute care, general outpatients, diabetics, MDTs, paediatric MDTs. He has a special interest in complex lower limb presentations. So currently, he also does some expert work for personal injury claims, and he's currently the lead clinician for a large study on microprocessor leg braces and their impact on quality of life and activity outcomes. As this session is only limited to 15 minutes, we better jump right in. So Dominic, welcome. And
Thank you.
when we when I think about orthotics, I kind of think about things like insoles, braces, splints, shoe raises, and that type of thing. But how would you describe what your role entails?
Essentially, I guess you could sum it up as if a condition could be helped with the external manipulation or application, redistribution of force, pressure, then there's a good chance that it might be something an orthotist can help with. Essentially, we will see a very broad range of conditions, but mainly where there's a functional deficit or pain. And then we will assess for, prescribe, fit, manufacture, braces, splints, supportive devices that can help manage that.
And I guess there's a difference to what's available on the NHS and what might be available privately through a personal injury claim, for example.
Yes.
Yeah.
There's quite a large difference. At the end of the day, sort of most people can be very well taken care of still with what's available through the NHS. Things that might be a bit stricter would just be maybe allowances, how many of the things you can have. But there are a few things which are just outside of NHS funding for essentially everyone, which is custom carbon fiber work and, like you said, these microprocessor leg braces, which we're part of the study we're doing is hoping that we can more easily access funding through the NHS for these sorts of braces, like was done not too long ago with microprocessor prosthetic knee joints.
When do you think this study will be completed?
So we've just started it. We had the first patients last week.
Okay.
So it'll be ongoing for about 12 months. The majority of the work will be done over the next sort of 4 months or so, but then we'll have periodic check-ins with these patients to see how they're doing over the course of a year, and just sort of collecting new data each time they come in. So hopefully a year.
Be interesting to see the results when they come out. But turning back to sort of your day-to-day work, most of the referrals we make through a personal injury claim will come via the case manager. And is there an optimum time for referring a patient to you?
Yeah, so I mean the optimum time for us to see a patient can definitely vary depending on what's happened. So there are a number of times where it's really beneficial for us to be involved straight away. In an acute care setting, someone's had a stroke, brain injury, spinal fractures, anything like that, where you've got the other teams coming in, your multidisciplinary teams, then it's good to get us involved early. Otherwise, it can often be the case of where when we have explored other options, they've had surgery, maybe they've had some physio, and people don't think that there's going to be more of an improvement or that their condition won't fully resolve and that they'll need some help, then they can come see us at a later point, once their surgeries are done, once their condition is sort of settled, and we know what this new baseline is that we're working with.
And as part of your initial assessment of a client, do you do gait analysis? And if you do, what do you achieve? What do you get out of doing that?
Yeah, so I mean, at a core level, gait analysis is something that we will do at every single appointment because it's basically just watching people walk and looking for stuff. We're looking for, I suppose, that initial assessment. Are there differences in symmetry, step length, speed? Are they having to make large compensatory movements to help them walk? Do they have balance issues, things like that? And then once we've given them a device, hopefully then we're looking for improvements in those areas. But in terms of what most people think of as gait analysis, in terms of video gait analysis in a lab, it's sort of overkill for your average assessment. It's not really necessary, but especially in terms of like a legal case, it could be really beneficial because you're able to really pinpoint and quantify a lot of data that you can then compare either as a before and after between different devices as well. If you need a funding, justification for stepping up to maybe something that's a lot more expensive, and the other party wants to know why would we, spend this much money, and then you can sort of show in quite clear terms what the differences are, and as well for like this study that we're doing, it's really beneficial so that way we can once again just quantify a lot of data, pinpoint certain aspects of gait, compare them to pre and post conditions, and look for statistically significant differences. So it's definitely something that is useful, but not necessarily needed for every single.
No, but I can see how beneficial it will be for in terms of the medico-legal process. So, and as you say, to try and secure funding.
Yeah.
I mean, the sort of common situations where in the past I've referred clients to someone like yourself is a situation where someone has had very complex fractures to the lower limbs with ongoing pain and difficulties with their sort of foot and ankle. And what kind of treatment modalities are there out there for that type of ongoing symptoms?
So once again, it really varies a lot depending on what's been affected, what level that injury has occurred at, or across how many levels as well, whether there is weakness as well as pain, whether they've had surgeries or like fusion, or whether they've had fusion but it's failed or hasn't worked quite how we wanted it to. But it can be, anything from insoles for sort of quite simple stuff where there's just pain on the underside of the foot, or maybe things just, since their injury, they just overpronate or oversupinate a little bit. What we see a lot, though, through especially personal injury claims is where there's, sort of complex polytrauma and there's quite serious and significant injuries. And that's when we can utilize things like custom carbon fiber offloading braces. And the real benefit to that compared to a traditional sort of plastic AFO is that we can completely immobilize the foot and ankle. So if they've got a lot of pain through their ankle whenever it moves, we can prevent that from moving, and similar to what a fusion, would achieve. And we can also then transfer that force away from the foot and ankle and utilize the I suppose, material benefits of carbon compared to plastic, which we can get this really great energy retention and return, whereas with plastic we can often just get a lot of deformation, and it absorbs a lot of that energy that people are putting in when they're trying to push off of it. Or as well, if there's, say, in the case of spinal cord injury, something like for us it's the tectus, but microprocessor full what's called a CAFO, which is basically a full leg brace from the hip right down to the foot. And with that, we can completely stabilize and control the knee joint as well. So if they've got significant weakness and that knee's really unstable, then with a device like that, we can really make a significant difference and help manage that.
And how does that work? Are you able to sort of show how it can make a difference using the detectors? Or
why do you ask that? I happen to have a couple of videos that we can show you.
Maybe if you're showing some videos just to sort of explain for the people that are just listening in rather than watching what we're seeing.
So this gentleman here had a spinal cord injury. He's ex-military, so he got his funding through Help for Heroes. That spinal cord injury has essentially rendered the majority of his right leg flaccid. He's got, I think he has, from memory, a little bit of strength in his hamstrings, which is why he's able to sort of maintain a little bit of that bend. But he's got some good strength in his trunk and his hip. And so then with the Tectus, or with any sort of microprocessor CAFO like this, where the knee joint is able to bend and unbend, we're able to achieve a largely sort of symmetrical walking pattern. He's able to walk unaided, so he doesn't need to rely on crutches, sticks, or a wheelchair anymore. He found sort of significant drops in especially back pain as well. And so what the knee joint here is doing is the microprocessor unit just sort of reading where he is in space, how fast he's walking, and it then adjusts the hydraulic resistance in the knee joint. So it can go from very high resistance, where the knee joint becomes very stiff or completely locked, down to a very low resistance, where it's sort of bending quite freely. And that's what allows us to essentially be able to have someone who's got no control over their knee to be able to walk with a bent knee without it collapsing. Whereas in sort of a traditional CAFO, often they'll just come fully locked. And so that leg is completely stiff, it is completely straight. And then they will often need sort of quite significant gait deviations in order to walk. You really need to pick your hip up really high, swing the leg out, and it can be quite an awkward way of walking, but it is still more stable than not using anything.
Sure. I mean, it's remarkable, the difference, and you can see how much difference that would make to this chap's daily life.
I mean, yeah, absolutely. And you know, Alex is a really good example, because initially as well, he didn't actually meet all the criteria. His hips are a lot weaker than they look in this video. He's utilizing a lot more of his trunk to actually swing his leg through, but with a lot of practice as well, it's become quite a fluid movement for him.
And was there a lot of, I mean, to get to the point where he's walking quite fluidly, was that fairly soon after you fitted him with the device, or did he need a lot of physio? And
so there was physio involved as well, and he had physio leading up to it in order to help focus on especially building that strength around the trunk, around the hips, and you know, maintaining joint range in his knee and his ankle as well. But it's a fairly rapid thing, especially on a nice flat surface like this in the clinic room. Most patients, I would expect very significant improvements in that session, and that they get accustomed to it quite quickly. If they're not, and they're really, really struggling, more than me thinking, oh, they just need time to get used to it, I think that there's an error with what I've prescribed, and we need to figure out what that is and adjust it accordingly, because these things should make a fairly immediate improvement to people's walking.
sure. And is there a sort of a minimum or maximum weight that someone could be to actually have?
At the moment, there is. With the Tectus, the weight limit is 100 kilos for this version. We're working on a second version, hoping to push it up to 125. There's another company called Ottobock who make a C brace, and the Tectus and the C brace are the only two at this sort of level. There are other microprocessor braces, but they don't use a hydraulic knee joint. They essentially just sort of lock and unlock as needed. They don't have that ability to transition through flexion under control. And I think for Ottobock, it's 125 kilos.
Okay.
There's also a minimum, which is 50 kilos, because if you're too light, then you just sort of don't have the ability to affect the hydraulics, and the sensors can struggle to sort of read the input as well.
Then is it only available for adults? Or, I mean, obviously the weight limit will have an impact for younger, but can a teenager maybe be fitted for someone as long as they meet the weight limit?
It is possible. The big concern would be growth of a child and how often they would then need to have the brace fully remade. This can happen in adults as well. Often after an injury like this, you will see changes in their leg over time. Those muscles will atrophy, their leg will shrink, and we will need to remake the carbon, eventually. But in pediatrics, that can be a lot more pronounced.
Yeah. Okay. It's really, really, I mean, amazing to watch the difference between the before and after videos.
Yeah. Alex and Paul here are quite good examples.
Yeah. Oh, you've got another example. This
is a below knee AFO. So this is the Momentum, the custom carbon fiber ones we were talking about. So Paul's had he had an injury to his right ankle. He's had a sort of significant degeneration since then, as well as a few surgeries. And he's very avoidant of future surgeries after what's happened previously. So he's sort of looking for anything other than a below knee amputation or a revision fusion surgery, which was essentially all that was on the cards for him.
Yeah.
And so what we're able to do with the carbon fiber is, once again, immobilize that foot and ankle in a position that is either as painless as possible. And not only does that help reduce his pain for Paul, it brings it from like an 8 out of 10 to a 1 to 2 out of 10. So it's still there, but it's very manageable. But significant increases, especially to his confidence, which is what we see a lot with the sidestepping.
You can see he's much more faster and more fluid, isn't he, in his sidestepping in the video?
Absolutely. And so, what that really equates to is then his ability to just do simple things like he likes to play with his grandkids and just go. He's an ex-paratrooper, and he still likes tabbing, so sort of going on long walks, hikes with his rucksack on, and and he can do that still.
Yeah. I mean, for that kind of device, and obviously someone who's had sort of a traumatic lower limb injury quite often can be left with a lot of scarring and maybe swelling. Is that, would they still be able to be fitted with something like that?
So often swelling is fine as long as it's if it's stable. So if the one leg is significantly more swollen, but the volume isn't changing regularly or rapid or sort of largely, then we can work with that. Where we really have an issue would be if it's fluctuating volume, or if we're just expecting that volume to go down in a sort of short time frame, then we would often wait till it's settled before we go ahead and start with something like this. Or else it's just going to result in a remake, potentially as soon as they get it. But we'll often use compression socks as well with these devices to help sort of, if they do have small fluctuations, which often they will with lower limb weakness, that they will tend to hold more fluid in that leg as those muscles aren't helping pump it back up. Then we'll use the compression socks to help mitigate that as well.
Yeah. Okay. Do you know, I don't know where the time's gone, but we're already up on our.
I went very quick.
So Dominic, thank you so much. It's been really interesting to learn about what you do and what products are out there for clients, and to our viewers as well. Thank you for watching this episode of Stewarts Soundbites, and we'll see you again soon.
Brilliant. Thank you for having me.
You're welcome. Bye.